Good evening, everyone. Welcome to yet another lecture of the EML Webinar Series 2020. I am Riya Esther, first year integrated MA student, the host for today's lecture. Today, we are honored to have with us Professor K.Srinath Reddy, President of the Public Health Foundation of India. Dr. Reddy formerly headed the Department of Cardiology at All India Institute of Medical Sciences and has also been a part of many World Health Organization expert panels. He also extended his services as the chairman for the Core Advisory Group on Health and Human Rights for the National Human Rights Commission. A member of the first National Science and Engineering Research Board of Government of India, he has published more than 500 scientific publications. Dr. Reddy was conferred the Padma Bhushan Award from the President of India in 2005 for his exceptional and pioneering contributions towards public health. Today, he will be addressing the much relevant topic, COVID-19, will a vaccine achieve population immunity? Sir, on behalf of the student community of IIT Madras, I welcome you to the webinar.
Thank you very much. Good evening, everybody. When I was invited to deliver this lecture and actually have a good interaction with the students as well as the other participants in this webinar, the topic that was originally assigned to me was challenges in delivering the COVID-19 vaccine in India. I thought the challenges, of course, need to be addressed both in terms of development as well as in delivery in this country. But some of them are going to be operational. But we need to look at how a vaccine can actually help in the population. Are there still some unresolved scientific issues? Even before we believe that a vaccine that is going to be available and that is going to pass all the necessary stringent tests in order to get into the delivery pathway. So that is why this has been modified slightly in terms of rephrasing the topic as, will a vaccine achieve population immunity? So that is generic to the whole world, but there are some specific issues related to India as well. So let us examine this, and then I look forward to, when we are talking about immunity, and immunity becomes the very important defense against this viral invader. In this particular case, a RNA virus, which has proved to be quite challenging to the whole world. The virus enters our body through three main portals. Being a respiratory virus, it enters through the nose, through the mouth, and also it can enter through the eyes, not only by causing inflammation in the eyes, but also passing through the nasolacrimal duct, which connects the eyes to the nose. It can enter the respiratory tract and then disseminate itself across the entire respiratory tract. Of course, we now know that this virus doesn't remain confined to the respiratory tract, and in severe cases, it spreads across the blood vessels, and it can affect virtually every organ in the body, and that's why the danger. But we have to look at what kind of immune mechanisms are developed naturally in the body, which can counter the invader when it first arrives. What are the kind of immune mechanisms that the body develops as it continues to fight the invader in terms of adaptive immunity, apart from the original innate immunity? And then how we can actually utilize a vaccine in order to provide protection against an infection by using some of the immunological principles that we are aware of, both before the COVID-19 arrived, from other viral infections, as well as from the gathering evidence on the kind of immune responses that COVID-19 itself, that particular virus, is now invoking in our body. So immunity can be either innate or adaptive. Innate immunity comes in particularly when we have good nutrition, good sleep, and generally keep away from addictive habits. and that builds up our innate immunity. Innate immunity is the first responder, and we have what are called cytokines and interferons, which combat the virus. Now, these cytokines and interferons, which are secreted by the macrophages, also attract the natural killer cells, which are already present in the body, and they serve as the first line of defense to try and contain the virus till the adaptive response of very specific immunological agents which are going to be targeted against this particular virus, whether in terms of what we call antibodies or in terms of cellular immunity. So the first defense is from the natural killer cells that have been activated by the cytokines that have been already secreted or the interferons. But we also recognize that the adaptive immunity, which is invoked by the viral infection itself and which has to be of a specific nature targeting the virus, is also going to be in two forms. One is going to be in the form of what we call humoral immunity, which is by way of antibodies, and other is by way of cellular immunity, which is by way of certain other lymphocytes. So, which are actually the B lymphocytes produce the antibodies, whereas the T lymphocytes are responsible for the cellular immunity. And these two components are very important indeed. And then we have also what are called the memory B cells and the memory T cells, which actually store this memory. And then whenever the invader comes in again, the body reacts by calling upon this memory. It may not have ready-made reserves of antibodies or other immunological respondents to the virus, but the moment it recognizes an old invader, it again activates that from the memory and provides a very potent response. So we know that some of the viruses have a very long-lasting immunological response. Measles, for example, the antibodies last for decades. On the other hand, common cold lasts for 1 to 2 years or even less than a year. But even where the immunological response seems to fade away, if the memory B cells and the memory T cells are fairly active and they've stored the memory well, then they can jump in and reactivate the process of producing the defense mechanism when the invader is spotted again. Now, in terms of the adaptive immunity, which is the immunity that the body develops in terms of a specific immunological response to the virus, as I said, there are B cells and T cells. The B cells are derived from the bone marrow, and of course they are subsequently produced by other parts of the lymphoid tissue all over the body, the various lymph nodes, etc. And the T cells are originally derived from the thymus gland, and they are also keeping on circulating and reproducing themselves from various other lymphoid tissues. So we see that these are the two important elements in terms of the adaptive immunity, which produces the specific antiviral defenses to each viral invader. But sometimes the initial response may not be all that potent, and therefore we may require a booster vaccine in order to produce a much stronger initial response. And that also provides you a much more longer lasting immunity. So that's why sometimes vaccines will have to be given as 2 doses, and that may not necessarily be there in the case of a natural infection, but in order to mimic the process of recognition of the viral antigen, sometimes a booster dose may have to be given. Now, as I said, we have the neutralizing antibodies. You see, antibodies can be produced, but the important function they have to play is to go and bind to the virus, immobilize it, and keep it from reproducing itself or replicating itself. So the neutralizing antibodies are very important. The body may be producing antibodies, but if it does not have the neutralizing capability, then the antibody is not of much use. So we have to also test out whether the antibodies are really capable of neutralizing the virus. And the neutralizing antibodies also invoke the help of what are called helper T cells. So those also come to the aid and support this function. Now, there are also other T lymphocytes called the killer T lymphocytes or the CD8 lymphocytes. They may help in picking off the virus-producing factories, but they will not prevent the infection altogether. So you have the intent of preventing the infection, which is the main function of the vaccine, not just trying to clear the virus factories after they've been established. So in this fairly complicated milieu of the human immune system, we are now trying to find out what would be the best way of producing a vaccine which can get effective initial response as well as a good memory that can trigger off recognition and a later strong response if the antigen is encountered again. Interestingly, there are also something called mucosal vaccines, which have not yet been very well tested in clinical trials, but they are under production now, at least in terms of laboratory development. Because what we are really talking about in terms of the current vaccines, which are using some of these immunological principles of stimulating the antibodies, which are usually the IgG antibodies, which are the neutralizing antibodies against this virus, that is something that is systemically provided to the body in terms of an injection into the body. On the other hand, there are also other kind of antibodies that can be produced, which are called the IgA antibodies, which are surface antibodies in the epithelium, and particularly they are produced in the mucosa. And if they are produced in adequate quantities, they may be able to block the virus from occupying the nose, because the principal portals of entry, as I said, are the nose, the mouth, and the eyes. And it is in the nose that the virus actually stays in terms of the maximum concentration. In fact, there are two special receptors areas in the nose where the virus seems to have a special propensity to make home, and from there it keeps spreading. Now, if you produce an IgA antibody, which is a mucosal antibody, it prevents the virus even from taking up residence in the nose. Whereas the other antibodies, once the virus has taken up residence, they fight it out as it spreads in the body, and they try and defeat it and contain it and then kill it. But here, you're even preventing it from taking residence. Therefore, a mucosal antibody, if it is produced, may have that advantage. But as I said, these are still in a very early development phase and not yet in full-fledged clinical trials. But it is possible that later on, we may be seeing this antibody, this type of vaccine also being produced. So now we are really looking at vaccine trials as important elements. Now, of course, how are we producing vaccines? There also we have had considerable progress over the years. First, it used to be something called the cell culture, and then we have had the rotavirus vaccine produced by DNA sequences becoming available, and reverse vaccinology approaches. And now we are also seeing viral vectored vaccines in Ebola, that is the more recent. And therefore, we are seeing advances in technology in terms of vaccine production. But however a vaccine is produced, and whatever the speed with which the vaccine is actually developed in the laboratory with all the new techniques, it still has to undergo some rigorous clinical trials. And there is that very essential requirement, which may be painful in terms of time delays, but absolutely important in terms of making sure that the vaccine is what we want in terms of efficacy, safety, and if possible, long duration. So we have trials in humans, essentially three phases, but there's also a phase 4, which we can discuss later. The first is the phase 1, which in a small number of volunteers, you inject the vaccine, and then find out whether it is safe or not. The immediate thing is there safety or not? Then in the phase 2, you increase the number of volunteers and then administer the vaccine again. In this case, you're looking for not only safety, but you're also looking for the right kind of dosage. What are the kind of antibodies that are being produced? Are they being produced in adequate quantities? Are they neutralizing antibodies? And is the dose something that has to be increased if it is insufficient? So essentially, you're partly looking at initial promise of safety, but also looking at the response in terms of efficacy for dose adjustment. But still, the numbers are not large enough and the process is not objective enough for us to judge how effective the vaccine is. So that is where we get into phase 3 trials, which is a proper randomized clinical trial, which usually involves thousands of people, because these are healthy people who are at the risk of exposure to the virus, and we want to prevent the virus from attacking them and causing an infection, even if they are exposed to the virus. And therefore, we require a large number of people to prove both efficacy as well as safety. And this is absolutely critical. And now, this is because, and then secondly, we also require, if possible, some idea of the duration of protection. Though a phase 3 trial may not be able to give you a full evidence of the long duration, at least apart from antibody production, if you can also demonstrate that there is a good T cell activation, then you're reasonably assured that the duration may be a bit long and not going to disappear in a few weeks or a couple of months. So those are important. But then there is also a phase 4 study. In a phase 4 study is what we call post-marketing surveillance. That means after phase 3, if you have passed the safety and efficacy tests, then the regulators usually allow it for use. They license it for use. And that after getting that regulatory approval, when the virus is now being used much more widely, still you have to actually record the experience as much as possible across the population, because the numbers are now increasing. Some side effects you may not have noticed in the trial, where the sample size may not have been adequate, may come forth, and then you may find out it's not as safe as it was believed to be. And secondly, you'd also get a better idea of the efficacy, because now you'll be able to record much larger number of infections in the population, and then find out what was the level of protection in the vaccinated people versus unvaccinated people. So that is the real world experience that we gather in the phase 4 trial. But as I said, it is phase 3, which is the real test for regulatory approval. Now, there is also something that people have been talking about in case of COVID-19 in order to cut short this process, because often the trials take several years. In fact, the last virus, the shortest time that a vaccine was actually produced and released with regulatory approval was 4 years. Here people want it within a few months. So people are saying, why don't we actually cut short the process? And some of them, like for example in China and Russia, have said we'll dispense with phase 3. We have got enough information about safety and some information of efficacy in our phase 2 trials, and therefore we're going ahead with the production. But that is not scientifically acceptable, because the numbers are not adequate to prove efficacy or even safety for that matter, and you're taking a bit of a risk. Others are saying, let us do something called the human challenge study. You know, human challenge study is a very interesting study, which was actually in the history of immunization, the first thing to be done. Edward Jenner, when he actually injected the cowpox virus into a boy and then showed later on that it was resisting smallpox, that was a human challenge study. He actually injected the boy with smallpox to demonstrate that the child was immunized. Now that can be pretty dangerous, and that is considered to be unethical. But now people are saying that if it is really so much of a problem in terms of the pandemic, it is infecting a lot of people, killing several people, paralyzing economy, why don't we cut short the whole process by doing human challenge studies and going ahead with it? But that's a hotly debated area. Ethicists will not accept it. And possibly, now that we know from our serosurveillance studies that a large number of people remain asymptomatic or mildly affected, and therefore the infection fatality rate, if you take all the people infected and the deaths, is going to be pretty low compared to the case fatality rate, where you are only taking the clinically diagnosed cases into account. So is it really worth doing a human challenge study? Even if it is a pandemic, it is unethical. So those challenges are coming in, and people are accusing the people in China and Russia that you are actually rushing through your trials without really undertaking the right kind of trial procedures and precautions. But anyway, that also brings us to the question of herd immunity. Now, why are we really chasing the virus in terms of providing a vaccine? Why not let people, if it is really not that serious, some people are dying all right, but if the mortality is not 3% or 5% or 7%, but if the mortality is 0.5% or less than that, if that is the infection mortality rate, then why not actually let people get infected, with some precautions, of course, being taken to protect the elderly and people with coexistent disease, and people will develop herd immunity, and that's the end of it. But then there are some issues related to herd immunity that we must understand. Firstly, for most of these vaccines or most of these viruses, the herd immunity threshold is considered to be above 50%. And for this virus, initially it was thought to be 60 to 70%. But even assuming it is 50%, the serological surveys that we have been seeing in India currently are not showing anything close to that. The highest in Delhi recently is of 29%. But remember, there are also some problems with the serological surveys, because the other coronaviruses, which include common cold viruses, can also produce cross-reactive antibodies. So you may be actually detecting antibodies which are against the common cold viruses when you're trying to search for antibodies against the COVID-19 virus. So you may be actually getting some false positives. And those of you who are well aware of statistics and mathematics would have heard of Bayes' theorem. And Bayes' theorem also tells you that a test has to be interpreted not only in the context of the test result, but also in terms of the pre-test probability. So a test that has been developed and validated in the laboratory on proven cases, when it is taken out into the general population for a serological survey, and with a large number of asymptomatic people, where the probability of infection is less, the prior probability, even if the test is positive, the post-test probability is not very high. And the false positives get amplified or magnified in a population survey. So it may not be 29% of Delhi, it may be just 20% of Delhi, and that is still lower than the 50% or 60% threshold for herd immunity that we are talking about. More importantly, there is another factor. It is actually not herd immunity, it is herd protection. The reason why this happens is, let us say that it is a 60% herd immunity threshold. And in that herd immunity threshold, we have, let us take Delhi as an example. Suppose 60% of the people in Delhi have been infected, have recovered, and are immune, then the virus has great difficulty in circulating in that population, because it is repeatedly encountering these immune people and it cannot get further transmitted. Whereas, and the remaining 40% of the people are protected, because these people are forming, even unknowingly, a protective cordon which prevents the virus transmission. So they're safe as long as they are in Delhi. But suppose they travel elsewhere in India they travel to Ranchi or Raipur, where only 10% or 15% of the people have been infected, and not 50% of the people. There is no protective cordon there. So even a person from this 40%, when he goes to some other place, is still vulnerable. So for all of India to get herd immunity at the level of 60% is going to take a long, long time. So that is why people say, let's not just leave it to chance. Let us try and get a vaccine and try and protect the lives as much as we can. And people with greater vulnerability particularly should be benefited. And we must stop this virus transmission at any cost. And therefore, a vaccine is our best bet to stop the viral transmission. That's the logic there. Now, as I said, there are three things we are looking for in a vaccine. That is efficacy, second is safety, and third is duration. Why are we talking about efficacy? Because every vaccine may not produce antibodies which are actually neutralizing the virus. There is something called the original antigenic sin. Because what is being injected in the form of the vaccine is not the virus itself. It is a part of the virus or a modified component of the virus. And it is possible that our immune system recognizes that as the antigen and produces antibodies against it. But when the actual virus comes in, our own immune system, which is supposed to react against it by recognizing it as the foreigner, and the immune system should have been primed against it, is not recognizing it because it's only recognizing the viral fragment that was part of the original, or the modified viral component that was part of the original vaccine. It is not actually recognizing the real virus. It is like, sometimes police artists ask for sketches to be made of a suspected criminal, and you have a very bad sketch and you go and arrest the wrong person. You don't recognize the real person. So like that, you may actually have a vaccine which does not recognize the real virus when it comes in. So that's called the original antigenic sin. Then there is also a challenge of safety. There is something called the antibody-dependent enhancement. Now, as I said, when the viral response, the immune response against the virus is invoked, then it goes on calling all these cytokines and interferons. They start invoking other other immune components. They start calling for reinforcements. And those reinforcements also come and produce various chemicals, including cytokines again. So it may so happen that this extra forces that are coming in to help, because the initial immunological defense has been cleverly bypassed by this virus, and it's been demonstrated that this virus has evolved mechanisms to bypass the initial immune defense. Therefore, the body, in panic, invokes much larger reinforcements, and then you get many more immunological cells activated, a lot of cytokines secreted, because the body now wants to batter the virus wherever it is, and it goes and attacks every part of the body indiscriminately and damages the body. And that is why you get respiratory failure, acute respiratory distress syndrome, where the lungs are frozen, and multi-organ failure. So it is a self-defeating immunological response that happens, and that is called antibody-dependent enhancement. Secondly, sometimes even if the antibodies are fairly effective and are binding to the virus, the immune complexes that are formed maybe start circulating in the blood and may start getting deposited in various bodies, especially in organs like the kidneys and so on, and they can cause more damage. So that is also the immune complex disease. So you have to make sure that the vaccine is safe. There is no way around it. Then the third is the duration, and that's where we get into the question of booster doses. Now for this vaccine, the currently produced vaccine, most of them are saying you have to give one dose and then after a month, another booster dose in order to get the right kind of immunological potentiation, which will stand for a long time and which will create enough memory B cells and memory T cells to stand in good stead for future recognition and future enhanced response. Then some people say, what about the duration part of it? So if it is going to be only for a few months, what's the big point? Why are we spending so much of resources on this? But others say, look, this is spreading very rapidly. It's causing a huge amount of havoc. But even if the vaccine gives 6 months of protection, we will be interrupting the dissemination. We'll be stopping the virus from moving around, and then it will die off on its own. So even that level of interrupting the dissemination chain is going to be worth it. So let's do it. So that is the argument that is being given right now. So let us say now that the virus vaccine has arrived successfully. So what do? Who do we prioritize for the vaccine? Do we prioritize the people who are most susceptible to infection? Do we prioritize the people who are most likely to develop severe disease if infected? Or those who are most likely to infect others? This is a very interesting question that we have to debate. Who are the most susceptible to infection? Healthcare providers and other frontline health workers who are regularly meeting a large number of people carrying the virus who are infected. And even if they're young, if they're repetitively exposed to high viral load from multiple patients, they are likely to be developing severe infection, and that's why you see doctors and nurses dying, even if they're relatively young. Same thing with security people who are checking so many people, some of whom may be infected in hospitals or in airports or wherever. So the people who are likely to be repeatedly exposed and therefore at a high risk will have to be given first. That's the argument. But then others will say, what about, yes, sure, but what about people who are also more at risk? Because people with hypertension, diabetes, chronic respiratory disease, on cancer chemotherapy with depressed immunity, these are the kind of people who are more, and elderly people, they are more likely to have much greater risk from the virus. They're more likely to die. A young person may not die, may not even feel the effect of the virus. So let us protect these people. So are they in the priority list? Then there is another argument. Who are the people most likely to infect others? Now, young people are moving around quite a lot. They like to mingle and mix. And they are the people who transmit virus to others, including the elderly at home. So why don't you immunize the people who are more likely to be moving around, and then so that they become immune and they don't carry the virus to others, and that way you are building a protective ring. That's another argument. Then, of course, who are the economically productive people? People in factories, people who are important in terms of developing a lot of new scientific products in the laboratories. All of these people who are economically very important resources, should they be protected? People are important for travel. Should the pilots and the train drivers and the airline crew, who are very important for travel, transport, and therefore the economy, should they be prioritized? All of these are the kind of questions that will come up. We'll have to answer them and triage them, but certainly try and create a mix so that people who are at most risk are prioritized first. Then how do we distribute? Do we hold camps, or do we use primary healthcare services to do household administration? Are primary healthcare services strong enough for that? Those are questions that will come in. Ideally, yes, they should be administered at home or near home. And if there's a good subcenter or a primary healthcare center, that's where they can be done. So, but all these are essentially also reflecting some of the weaknesses of our existing health system. Then comes the question of the center versus the states. The center says states are not going to be procuring any vaccines. We will be procuring the vaccines. We will be distributing the vaccines. Leave it to us, because we'll make sure that we'll strike a good bargain with the industry. We'll get it at a fair price. We'll get it from national and international sources, and we will distribute as per need, and we'll set the priorities of who will get first, which categories of people will get first, and then accordingly we'll distribute. If there's a mad rush and states start competing with each other, there'll be chaos, and we don't want that. So we'll have to see how that proceeds, how efficiently and equitably that distribution will be done. But that is assuming that we have a safe vaccine available. But will it be available for India, and at what cost? We have 3 vaccines now which are being tried out, which are likely to come out into the Indian market from India. One of them is actually a borrowed vaccine from Oxford, from AstraZeneca, but mainly produced by the Oxford group, which the Serum Institute has done a smart thing. It's called at-risk manufacturing. They took a bet on it and said, okay, you send us the vaccine, which you have tried out in your phase 1. We will also try it in our phase 1 and phase 2, and we'll also try and do a smaller phase 3 trial. But in the meanwhile, we are going to produce a huge amount of vaccine, and we will supply it within India, and we'll prioritize, of course, within India, but we will produce within India at a lower cost. So if by the time your trial is ready, and Oxford says it will have its phase 3 completed by September, even if it's October or December for that matter, by the time the regulators examine all the data and it's given the green flag, the Serum Institute would have already manufactured and ready to go. Then you have Bharat Biotech partnering the ICMR, because ICMR developed the vaccine, Bharat Biotech is manufacturing it, and we'll have to see. They have also entered now phase 3 trials just now after phase 1 and phase 2. We still have to see the phase 1, phase 2 data in the public domain. They've said they're going to start phase 3, but then we'll have to wait and see when their results will come out. And third is a Zydus Cadila vaccine. So all 3 of them are now in different stages of the human clinical trials. But then, is it going to be available at a cheap rate? If it is an international vaccine that has to be imported, they're going to be charging a huge amount, maybe even hundreds of dollars. Whereas, if it is produced in India, Serum Institute says that they will supply it at about $900 to $1,000, or even Bharat Biotech says that. So let us see what price controls the government of India will impose. But government of India says we will absorb the cost and we'll supply it to everybody free. So we'll have to wait and see. Now, there are international vaccine partnerships led by the Global AIDS Vaccine Alliance, the Gavi, which has also stepped into this and said that we will now try and the Global Vaccine for Alliance for Vaccines, Gavi is also now stepping in and saying that we will provide these vaccines at a lower cost, and they are developing some international partnerships. So then the World Bank is also saying that they will also supply to some of the countries who are eligible for their international development assistance program. Now, as I said, what about schools and colleges? How are we going to prioritize them? I've talked about different categories: healthcare providers, national security forces, other essential workers, people at high risk of getting serious infection, or whoever is spreading fast. And some people are saying that let us try and contain the spread by trying to vaccinate the people who are moving around a lot, including the young people. So those are all the kind of categories we are really looking at. Others are saying more than 65 years, or those with comorbidities, or those with poor health. But what about people who have to go to schools and colleges? Do we prioritize them first, or do we keep them later? Because they're young, but then the teachers are at risk. And secondly, the young people can carry the virus back home to the elders. These are all going to be challenging questions. And because we are going to be producing it in batches, have to then see how we can distribute it well. Now that is about the whole gamut of immunology in terms of the response to the virus, the adaptive immunity that the body develops, how we can actually utilize that knowledge to produce a safe an effective vaccine and try and see whether we can actually depend upon it to have a reasonable duration of effect and whether it's going to be available across the world. All of these are the questions we need to address. We have made some progress in the last few months, but still there are several unanswered questions, and we'll have those answers only in the next 3 or 4 months at the earliest, and perhaps early next year. But till that time, we'll have to keep our safety precautions going, including physical distancing, masks, hand hygiene, and avoiding crowds, especially indoor crowds. Those safety precautions must go on because there is no sure bet that we are going to get a perfect vaccine, which is safe, effective, and of long duration. Right now, we are investing in hope while using science for research. We'll have to wait and see whether we can deliver on that hope. Thank you. I'll be happy to take questions or comments.
Thank you, sir. Thank you for sharing your wisdom and insights on vaccines, herd protection, crowd immunity, and helping us develop a broader understanding of this whole pandemic scenario. So we have received a few questions from our audience, so now we'll move on to our Q&A session. So the first question that we got is, what is the future of telemedicine in India, especially in the current COVID-19 scenario where people are hesitant to go to hospitals?
Well, one of the things that has happened in the context of COVID-19 epidemic is a regulatory change. Previously, partly because some of the doctors were not permitted to undertake telemedicine by courts. There were court judgments which said that unless you physically examine a patient, you cannot prescribe. And giving advice by telephone or from a distance is not permitted. So it was made illegal. So while the rest of the world was experimenting with telemedicine, there were a lot of barriers to telemedicine in India. However, with COVID-19 coming in, the lockdown has restricted mobility by half the distance, and whether it is advising on high blood pressure or diabetes or any other ailment which does not require physical presence immediately in terms of dose adjustment or in medical treatment, telemedicine can be useful. So now the regulation has been definitely changed in order to permit. But to some extent, it is helpful for an educated patient or a reasonably health literate patient who can actually communicate with the doctor and get the advice. But what about number of others in primary health care? So even for telemedicine to be properly provided, you need your frontline health workers to be available who can actually utilize this telemedicine facility to get the advice from the doctors and provide appropriate services to the people at the frontline level. So we do need to strengthen our health system. Telemedicine can be very useful, but it cannot be the only solution to our health system challenges.
Thank you, sir. Another question that we got is, can you talk about histocompatible reaction in the post-production of vaccine at COVID-19?
Well, basically, you are really looking at the vaccine necessarily being safe and effective, and it should be generally applicable to all people, irrespective of their histocompatibility, human leukocyte antigen patterns. But if there are any specific proclivities for reactions or differences in efficacy, that will be known partly during the trials, but during the post-marketing surveillance, you'll know much better. But right now, they will be testing it even during the trials themselves to see if there are subgroups who behave differently from other subgroups.
Thank you, sir. The next question is, will the vaccine be less effective in overweight and obese individuals?
Well, overweight and obese individuals are anyway at much higher risk of getting severe COVID infection and severe complications. But whether they require a higher dose, whether to get an adequate immunity, that we'll have to wait and see. But it appears that the vaccine dose would be tested anyway in people who include a fair amount of overweight people. If you are doing a lot of vaccine trials in the USA, obviously you're going to have a large number of people who are overweight in the trial population. So that's going to be less of a challenge for India, much more of a challenge for USA, Mexico, and some European countries. But it is possible that there could be dose differentiation.
Thank you, sir. The next question is, how accurate do you think are the mathematical models which predict the pandemic to end in India by November?
See, the problem about mathematical models is they are based on two things. One is available data, and second is assumptions. Now, our data availability is not perfect, either in terms of quantity, of adequacy of coverage, nor in terms of quality. So we have some serious data limitations. And secondly, we also have challenges in terms of assumptions. There are a number of assumptions that were made at the beginning. For example, in India, people said millions of people are going to die by June. And the various forecasts that were made for India did take the age profile into consideration. They directly applied to the Indian age structure and the population size figures that were coming from China and Italy, where large number of deaths were initially being reported. They didn't take into account, for example, that India has a very large rural population. And in rural population, the virus spreads much more slowly because unlike an urban population where one person meets many people and travels a fair amount of distance during the daily work life, in rural populations, one person during the course of the day meets fewer number of people and does not have to travel far for work. And thirdly, there are far more open spaces in rural areas, unlike closed office spaces in urban areas. And you also don't know, some of these models also sort of took into account equal susceptibility of every individual, whereas different individuals have different susceptibility, both for infection and for death. And there are also things called super spreaders, where it appears that 20% of the people are responsible for 80% of the infections. Whether they themselves are having higher viral loads or not, we do not know. But there are super spreader events where people gather in large numbers, particularly in indoor spaces, and they can create huge super spreader events like we have seen in different parts of the world, whether it is bars in South Korea or whether it is restaurants or churches as well, or things like that. Wherever people gather in large numbers, you can actually have super spreader events, or even barbecue parties outside also, where people crowded together. So these are things that modelers have not taken into account. Now you have to keep remodeling every time, taking into account a number of new variables that are being proposed. But essentially, many of these models are not perfect, and we cannot really predict that this is exactly going to happen by November, as has been suggested.
Thank you, sir. The next question is, as per the present available data, once vaccinated, how long will it give protection and what is the efficacy ratio?
We do not know. We just do not know yet. because if you're only going by the antibody response to the real virus, the antibodies are disappearing in 3 months' time. Now, the people who are now testing the vaccine are saying that they're also studying the T-cell immunity, and even though the antibodies seem to be falling, the T-cell immunity or the cellular immunity is also stimulated, and that may last a longer time. Therefore, we do not know yet how long this is going to last, both in terms of neutralizing antibodies and in terms of cellular immunity through T lymphocytes. But if it lasts even 6 months, it may be of some use. If it lasts 1 year or 2 years, it may be of some use. You see, for example, in some of the other viral diseases, like influenza viruses, you also repeat the doses almost every year or 2 years. And that's also partly because there is a challenge of mutation. If the virus mutates substantially, then you totally lose the impact of the original vaccine. You may have to change to a new vaccine. So the whole idea here is there is hope that this immunity will last beyond 6 months. And during that period, you'll be able to interrupt the cycle, and you will be able to stop the virus from finding new victims and new pathways of spread. And therefore, by breaking the chain of transmission, you're ending the epidemic. We'll have to wait and see.
Thank you, sir. The next question is, what's your take on reporting the cycle threshold value of RT-PCR test in assessing the infectivity of an individual? How much a PCR positive person can spread the virus if his CT values are low?
I think the Director General of ICMR has clearly answered this, that he said cycle values are not predictive of the spreading and the propensity to spread. Therefore, investing a lot of time and money on the CT values is not correct. So you have to really look at each person who is showing a viral positivity as an infected person and treat the person under isolation till the person becomes asymptomatic, at least for 3 days before a discharge. And of course, now we have the challenge of the dead viruses also. So they've stopped doing repeat tests, but the clinical progression has to be seen. But as I said, it is not just the question of how rapidly the virus is replicating itself. It is also that how is it going to behave in a human being who may have comorbidities, whose age profile may be different, whose pre-existing immunity because of either innate immunity or maybe BCG immunization or common cold coronaviruses or polio immunization. You cannot really talk about that laboratory value, CT, and then say this is how a human being is going to react when the virus gets in. Therefore, the Director General of ICMR has made it very clear that do not spend too much time on that.
Thank you, sir. The last question we have is, how can we respond effectively to fast-moving diseases?
Okay, it's a challenge. It's a very interesting challenge of evolutionary biology. I hope some of you people in IIT will also study evolutionary biology. There is usually a trade-off between virulence and infectivity. It doesn't happen immediately. Now, what happens is that these viruses have come from wild animals. In the wild animals where there was a very confined population of those animal hosts, the primary hosts, the viruses were not very virulent. They remained relatively calm and quiescent, didn't cause too much damage to those animals, because if they killed those animal hosts, then their own species would not be able to replicate itself and survive. Then we create the conveyor belts for them to enter captive veterinary population by breeding livestock and poultry in large numbers and then bringing wild animals into the wet markets, or deforestation, extensive deforestation for urbanization, for mining, for agriculture, and we create an interface, very open interface between wild animals and the viruses and vectors contained in the forest into the veterinary population and into the human habitat. And once these viruses find large new hosts, they can afford to multiply fast, but also grow more virulent. And they can spread very fast. But there is usually a trade-off between virulence and the infectivity. Because if you're very, very infected and also very, very virulent, then you're going to be killing off your host very rapidly and in very large numbers. Then the virus is shutting the door for its own species to survive. So the virus, as it rapidly multiplies, tends to become less virulent. That's why you find that some of the more virulent viruses like SARS and Ebola were not that infective, whereas this virus is highly infective and less virulent. Therefore, the answer to the question is, what we need to do is, of course, try and create roadblocks for these viruses from traveling. We have to create a bumpy road. That's why the physical distancing, masks, avoiding overcrowded events, so that the virus cannot easily travel. But thereby, we are also giving a stimulus for the virus that I'm not getting enough of a host. And if I have to survive, my species has to survive, I have to mutate to a less virulent form, because otherwise I'll exhaust my limited host. So we can also use evolutionary biology to nudge the virus back into a less virulent form. So for fast-moving viruses, the answer is create roadblocks, physical distancing, hand washing, masks. Those are the way we can actually prevent the spread. But at the same time, take the bigger lesson. It is our ecological despoilation that is creating a huge series of zoonotic infections. In fact, in the last 50, 60 years, about 70% of all new outbreaks have been zoonotic, from animals to humans. It is not because animals have suddenly become malevolent towards human beings. We have created the conveyor belts. So even as we explore science at its very best at the molecular level, in order to create vaccines, we need to have that larger ecological picture and commitment not to disturb the ecological balance.
Thank you very much, sir. We are truly honored and gratified to have hosted you. I would also like to thank the viewers for joining in. Thank you.
Thank you very much. It's a very pleasant experience, and I hope some of what I've said is of use to the viewers. I'm sure most of them have had this prior knowledge, but if I've clarified a few concepts, then I feel my work has been done. And thanks again for this wonderful interaction.
Thank you, sir.